Welcome to the ASCO Update 2015 here in Zurich. Now we are going to discuss the practice-changing studies in gastrointestinal cancer. Joining me today is Dieter Köberle from Basel. Dieter, could you now briefly summarize what was found in the CERFLUX study, which affects probably quite soon our current treatments?
Yeah. The CERFLUX study is a phase 3 trial, randomized trial in patients with metastatic colorectal cancer receiving first-line chemotherapy. And in this study, third was given in the first cycle of chemotherapy. So basically all patients got chemotherapy. Most of the patients allocated to the third group also received third. Only 7% did not receive third for many reasons. And the result was that the progression-free survival, which is the main primary endpoint of this trial, was similar in both arms. So this is basically a negative trial. However, they looked to the group with liver only, and only the liver PFS, they called liver only PFS, and this PFS was prolonged by 7 months. So basically from 12 to about 19 months in the liver.
So you can stop progression in the liver by that?
Yeah, you can stop progression and really gain some months by one treatment with third.
What is the clinical impact of this?
Well, I think it's an eye-opening result in terms that it indicates that third might add to the progression-free survival and possibly also to some degree to the overall survival results. We don't know this yet because they did not report on overall survival. They give us the result probably in 2 years from now, and they will mix up 3 trials asking the same questions, and then we get the result on overall survival. So the major question is, do patients live longer, is still open. However, we know that especially if there's limited liver metastasis, third may add activity in the treatment. And I think it's already time to move third from the last place in the treatment more to the frontline treatment. I'm not quite sure if it's really best given in parallel to chemotherapy or after first-line chemotherapy, but I think there is indication that third might have a new role in the earlier treatment of patients with liver metastasis from colorectal cancer.
Okay. But the exact place has to be found, and it's difficult to decide at the moment, I guess.
Correct.
How to interact.
This is rather proof of principle, but there is still things open which need to be designed in additional trials.
Now, another really interesting study was the HERACLES study. This was done in advanced colorectal cancer patients HER2 positive. Could you briefly summarize the study?
This was a study done in Italy mainly. They looked also to a group of patients with metastatic colorectal cancer. Most of them received already 2 or 3 lines of palliative treatment. And they screened for HER2 positivity, mainly immunohistochemistry positivity, but they did also FISH testing. And then they looked into the group with HER2 positivity if a dual treatment with non-chemo agent, trastuzumab plus lapatinib, this was one cohort, and there's a second cohort with pertuzumab and trastuzumab, which was not reported at the meeting, if this has any benefit on a patient with HER2 positive colorectal cancer. And the answer is yes. The response rate was about 35%, and the responses were durable. So this is a nice sign that really we have a new type of treatment, a non-chemo type of treatment in this subgroup of patients with HER2 positive colorectal cancer.
Was there also a difference in the findings regarding HER2 expression?
Yeah, we got the impression based on a very low number of patients that those patients where they found a 3+ immunohistochemistry staining got a little higher degree of benefit than 2+ staining. So the positivity was defined as either 2 or 3+ staining, and in the subgroup of 3+ staining there was already higher response rates found.
So in those who express really strongly the HER2, we have to consider this treatment option?
I think yes, it's proof of principle, and the drugs are already available. The test is easy with immunohistochemistry and quite validated and available throughout the centers. So we can test patients for the HER2 positivity, and we can have access to the drugs. We know how to combine the drugs. So the side effect profile is rather low. And yes, I think we should start to screen patients for this HER2 positivity and decide if we can get these drugs and if we can get reimbursement for the costs of the drug as well. This is an off-label treatment for sure.
Okay. Now, there were also many negative trials. Would you like perhaps to summarize a few of them?
Yeah, there were quite some disappointments, especially the MET story. Appears to be over in gastric cancer. There have been reports from 2 major trials assessing chemotherapy plus or minus an anti-MET agent in patients with MET-positive gastric cancer, and both trials were completely negative. There's a very small subgroup where MET might have a role, but it's not really defined. Maybe we should look not to immunohistochemistry, but rather to FISH testing or molecular testing, but the story is more or less over. And there is also disappointment about, for example, Tarceva in combination with gemcitabine in the adjuvant treatment of pancreatic cancer patients. This trial was also completely negative. Even those patients who has the skin rash during Tarceva treatment did not gain any benefit in terms of progression-free survival or overall survival. So negative trials.
Okay. Dieter, thank you very much for this really nice and comprehensive overview of the studies in your field.
Thank you.